السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير. Pleasure to introduce Dr. Omar Altamimi. Dr. Omar, he is a consultant pediatric cardiologist and interventionist in King Fahd Medical City. He is one of the figures in pediatric pulmonary hypertension. Dr. Omar Altamimi is going to give us a talk about the persistent pulmonary hypertension in a newborn with TGA, the hidden enemy. Dr. Omar, the floor is yours.
شكرا دكتور أحمد. السلام عليكم ورحمة الله وبركاته. Thank you for attending this activity, and it's my pleasure to share with you this presentation. In fact, we saw a few cases or referred to several centers in very bad shape, which is they died, some of them, before they go to the surgery. And this is very important to note the importance of the care and recognizing the most enemy in the patient with congenital heart disease. So I have no disclosure for this presentation. For pulmonary hypertension, the DTGA, it's accounting for 5 to 7% of congenital heart disease. We give them two classifications: simple DTGA and complex DTGA. Simple DTGA is a patient with transposition of great artery with intact ventricular septums, BFO, and usually a BDA. And the complex one is the one which is associated with ventricular septal defect, left ventricular outflow, obstructions, or coarctation of the aorta. The persistent pulmonary hypertension of the newborn, unfortunately, it's occur between 5 to 20% of the newborn with DTJ, and it's common in the simple type of DTJ. And unfortunately, this is more higher than the normal term baby who has no congenital heart diseases. And this is very important to be recognized, as most of the patients we are talking about, almost 1/5 of the patient, they will have a PBHN. So DTGA with intact symptom, the surgical mortality usually in normal patient is around 2 to 5%, most of the time in around 3%. Patient with PBHN, the mortality, operative mortality is going up to 1/5, almost to 1/3 of the patient. They can die during the perioperative period. And this is very important to recognize this important issue in the patient of transposition. Most of us was focused on the coronary transposition, but this is very important things, which is really should be recognized by the cardiologist, by intensivist, neonatologist, and before they introduce the patient to the surgery. So what happened in the transpositions? In the normal transpositions, we are talking about two parallel circulations. The deoxygenated blood coming from venous system, superior vena cava and inferior vena cava, going through right atrium to the right ventricle to the aorta and back to the bodies. So the other circulation is the pulmonary vein back to the left atrium to left ventricle to the pulmonary artery. Without mixing, this is usually the patient will die immediately. And this is very rare to have no mixing. So what's the mixing between the two circulation is BDA and BFO. The BDA usually, and this is not a mixing site, but it's usually driving the blood from the systemic circulation to the pulmonary circulations. And the beta interferon oval or the AST is the area where is the mixing at that level. And this is very important to be recognized, because if you see, this is the dark black arrows is deoxygenated blood. Once it's mixed with the white arrows, that it's become less dark, and that means the more the mixing, the more pink the patient. So it's very important. But what happened exactly in some of the cases, the minute you start prostaglandin, the LA pressure is going up, the BFO valve start closing, and the patient deteriorating after starting prostaglandin. And this is just because of the BFO. In the patient who has really inadequate intracirculatory mixing, Usually they will have severe cyanosis, they will have lactic acidosis, and usually they die. This is very important to be recognized in the physiology of the DTGA. So intra-arterial communication is the usual site of mixing in normal physiology. VST when you have severe left ventricle outflow obstructions. So that means that balloon atrial septostomy or creation of the good atrial communication is very important in the setting of transposition of the great arteries. VST is not a mixing site if there is no good atrial communication or there is no significant left ventricle outflow obstructions. Also the BDA is not a mixing site. So what happened in the patient with BPHN? Again, we go to the same diagrams. If you see the dark black arrows, this is the deoxygenated blood coming back from the body. This is deoxygenated to the right atrium because of BPHN. The left atrial pressure is very low. So the shunting will be from right atrium to the left atrium, from the left atrium to the left ventricle. And you see the BDA is reverse shunting instead of coming from the systemic flow from the aorta, from the left to right, it's become reversed and become from the left side, which is the pulmonary circulation, from pulmonary artery to the aorta. And this is very important. That means this is a reverse of the norm. And this is, which is I told you before, the BDA is not a mixing site. So what happened that the oxygenated blood coming to the LA mixing with the LA high oxygenated blood going to the left ventricle, and the same thing, this is how mixed with the left ventricle and going from the BDA. And this is create differential cyanosis. So you will have the upper part of the body is cyanosed and the lower part is less cyanosed in that. And this is very important. This is creating poor oxygenation, cyanosis, tissue hypoxia, and acidosis. So what is the sequences? And just as very important, because this is a circle, and you have to cut the circle. If you don't cut the circle, the patient will deteriorate it, and usually they will die. So what happened in DTGA with pulmonary hypertension, high pulmonary vascular resistance, high PA pressure, suprasystemic PA pressure, you will have reduced pulmonary flow. The flow is coming from the left ventricle to the pulmonary artery, and from the pulmonary artery back to through the BDA back to the system. And this is very important. You will have a reverse cyanosis. You have BDA right to left, B of O is right to left, and the VST is usually a normal patient with small VST is usually the flow is from the right systemic ventricle, right ventricle, to the pulmonary ventricle, which is the left ventricle. So you have a difference reversal. You see that the VST is having a flow from the left ventricle to the right ventricle. So during this episode, you will have acidosis, and this acidosis is mixed metabolic and respiratory, because there is no enough flow to the lung, so the CO2 will go up. There is no good oxygenation for the body, so there is a metabolic acidosis. This is vicious circle will go to back to the pulmonary. The pulmonary resistance will go worse and worse, and the patient become more worse in this vicious circle. You have to cut this vicious circle by reducing the pulmonary vascular resistance. This is the best way, correcting the acidosis, improve the oxygenations. This is very important for the people to recognize. This is vicious circle. You have to cut it to improve your patient status. Otherwise, it's in a few hours maximum, he will be a dead patient. So when I should recognize there is a BPHN, because it's not all the patients with DTGA have BPHN. So we are talking by the maximum is 1/5. So it's the patient's very sick. Usually most of the DTGA is born, they are okay, they are stable, even they can wait for hours, then this is very sick. He's hypotensive. He needs inotropes to improve his blood pressure. He's acidotic. He has hypercyanosis, that means differential cyanosis, that means hypercyanosis in the lower limb is better, the postductal is better than preductal. He has acidosis, he has oligemic lung, And the echo, it's very important when you're doing the echo. You will see underfilled left atrium. B of O is right to left. That means, which is very important. It's usually in normal TGA is the shunt, and the B of O is from the left atrium to the right atrium. BDA bidirectional flow, and very important, if you see BDA with bidirectional flow, this is high pulmonary vascular resistance. If you have a small VST with the same I told you, with shunting from the left ventricle to the right ventricle, left ventricle is the pulmonary ventricle. That means this pulmonary ventricle is higher than the systemic ventricle, and this means pulmonary hypertension. And this is very important for interventionists. When you do the balloon arterial septicemia, they don't improve. They don't go up. Usually when you do balloon septicemia and transposition, most of the time you go to high 80 to 90s in saturation. You do balloon septicemia, they don't improve. This is very important. This is a patient, you should recognize this is a patient with BPHN. I will give you some of the cases I saw in a few weeks. This is a patient who has bidirectional flow in the BDA. You see the BDA here is blue and red. This is very important, alerting things. But the good thing here is he has filled left atrium. The left atrium is engaged. And you, as I told you, that when you have left atrium is full, the BFO valve is going to close that and reducing the communication and shunt in the at the level of the atrium. And this is one of the cause of deterioration. And this patient is luckily, when we do septicemia, in few hours of inotropes, if everything is okay, and we manage to extubate the patient. The second case, you see this case is another case, which is if you see the 4 chambers, the contractility is not that good because of acidosis. The left atrium is smaller than the right atrium, which is underfilled left atrium. BDA is clear, bidirectional flow. And when we do septicemia, immediately, even that with this big BDA, still there is bidirectional and at the level of the AST. That means the left atrium is still lower volume, low flow to the pulmonary. This is pulmonary hypertension. We started with nitric oxide, and luckily this patient survived it. The third patient, which is unfortunately, we cannot do much for him. This is a patient who is very clear. You can see dilated left right atrium, small left atrium. BFO is clear. There is a shunt from the right to the left. BDA is almost all that. It is coming from the pulmonary to the artery. And this is very clear. This is severe pulmonary hypertension. This patient has severe acidosis, and he doesn't make it. If we do septicemia, he doesn't survive it. This is very important. This is 3 cases. You have to remember that you can have mild type, you have moderate type, and severe type, and you should recognize them before you lose them. Now, so what should we do? It is very simple. Urgent balloon arterial septicemia. Start nitric oxide. If you don't have nitric oxide, try to use another pulmonary vasodilator. Sildenafils, bosentans, whatever you can have. Correct anemia, correct acidosis. Keep hemoglobin more than 14, and correct the acidosis aggressively. Ventilate the patient, paralyze him, minimal consumption from the tissue. Normal or low beep, and be careful from any pneumothorax. Fluid management, good fluid management. You should not restrict the fluid management unless there is a good causes. Inotropes, and this is very important to avoid hypotension and hypoxia. And if there is a sepsis, treat the sepsis. This is very important thing. It's very important to save the patient. You know that this is one of the diseases which have low surgical mortality. It's very low surgical mortality, and the long-term survival is good. So we should try to save them and their life as possible as we can. Otherwise, we still will keep losing between 5 to 20% of them. So what is the natural history? Without quick and time intervention, or response, usually they will die. This is the lethal one. With time recognition and intervention usually resolve within few hours. And usually the intensivists, they recognize it and they know it, they see it a lot, that the minute the patient coming from the cath lab with nitric oxide, in a few hours you start weaning the inotropes, and the second day they are ready to extubate him. And this is very important to save a life. And this is very important for everybody dealing with the congenital heart diseases and TGA to recognize it early, start the treatment early, and saving the life. So the home message is very important. Early recognition and intervention will save a life. The BPHN can develop anytime in the course of DTJ. Early stable patient can undergo a severe episode. Keep in mind that decreased oxygen saturation, hypotension, and acidosis may be the initial sign. And this is very important. Keep nitric oxide ready in the unit for any emergency. Thank you very much.
Thank you, Dr. Omar, for this nice presentation, which touching very important issues with those babies with transposition of great arteries and needs very aggressive management to avoid mortalities. So the floor is open for discussion and for the questions. Anyone has questions, he could write it in the chat box, and Dr. Omar, he will answer. Anyone also has any comment, he could add any comment.
Assalamu alaikum.
Alaykum assalam wa rahmatullah. Dr. Ali,
Dr. Omar, for this nice lecture. How we can recognize that the patient or the patient with TGA is having or susceptible to have BPHN prior to birth. I mean, during fetal life, I think we can diagnose or expect that the patient is having is susceptible to have BPHN, so that we have to be ready for either early surgery or to start nitric oxide.
Good question, Dr. Ali. Honestly, I read the review, most of the literature, and I have no idea if there is any good sign to tell about the BPHN, even in the normal baby, not in the TGA. But if you have any idea, Dr. Ali, you can share it, because the only idea which is I know it is the patient who has premature closure of PDA may have BPHN, but I didn't know about the other side. So, Ali, do you have any idea about this?
I have actually I wrote a paper regarding pathophysiology of or circulation in patients with DTGA. It was published. I didn't remember exactly the points regarding the fetal echo diagnosis or suspicion of BPHN in patients with DTGA. It was written, but I have to revise the points regarding this matter.
Okay, thank you.
Abdullah Tayyib. Dr. Abdullah Tayyib.
Assalamu alaikum, Dr. Ahmed. Assalamu alaikum, Dr. Omar. Thank you very much for your very nice lecture, very concise and to the point. Dr. Omar, I have question regarding, I have many questions, actually 3 or 4 questions, but the most important question to me now, if I have a baby who is not sick, not ventilated, but his pulmonary pressure is high, 2/3 of the systemic pressure, he's not ventilated, he's not on any inotropes, and his LV is dilated, which is the subpulmonic ventricle dilated significantly. The measurement of the pulmonary pressure is 90. I mean, 2/3, more than 2/3 of the systemic pressure. So what we are going to do for such a patient?
Well,
The
I think this is very
atrial
clear.
septum is adequate. The atrial septum is adequate, and there is BDA, which is very closing, almost closed, and the patient is not sick.
Yeah, this is very clear patient, which is usually they are in transitional period. You don't know where they will go, here or there. You can wait for them, but you should be just alert for any deterioration. You should start pulmonary hypertension medications. This is clear that it is in the transitional, and you know the BPHN it's a matter of transition from the fetal life to the adult life, to the normal life. It's postnatal life, which is sometimes they don't go to the normal transitions, and some of them they are slow in the transition. But if this is the case, if the patient is stable, he's not need anything, I will watch him, but I will not let him go from outside from the unit until he resolves his BPHN. Still, he has BPHN, but he is in the progression of the resolve. But if he's deteriorating, anytime I will go aggressive with him.
Right. Yeah. This is our plan today. The next question: what about the rationale of stopping the prostatin immediately after balloon atrial septostomy? Is it the absolute practice? Is it what if we need to resume the prostatin after the septostomy? Because there is a debate still in this point between intensivist and interventionist regarding this prostatin continuation or discontinuation immediately after septostomy.
Well, it's the mixing level, and the TGA is the atrial level. Now, if you have a PST or anything which is pushing blood to the pulmonary circulations, you will not worry about the closure of the BDA. Now, if it's not that, then you are depending on that between the mixing in the atrial, right atrial and left atrial circulation. If the patient have a spontaneous breathing and is not need any oxygen, he's okay, he's extubated, he's stable, I think stopping of the extra blood to the lung, it may be a wise one. But as you know that all the data suggesting not all the patients you can off the prostaglandin, some of them they need extra blood to the lung. But if the patient is ventilated, the problem with the ventilation, as you know, doctor, is that is the positive intrathoracic pressures and is swinging of the intrathoracic pressure with the ventilators. So most of the time, if you stop the prostaglandin in the ventilator, most of the time you need to resume it in whiles before. So most of the people, they just wait, extubate the patient, then stop the prostaglandin, give him the trial.
My point that if this patient underwent septostomy, still he just came and we tried to wean the prostatin, we stop it, and then the baby deteriorate. He became acidotic, lactate raised up, and then there will be the fight between us and you interventionists. That's why you resume the prostatin, and we said no, the patient did not tolerate. So what can you say regarding?
No, this is fact, Dr. Abdullah. This is fact that not all the patients they can have a mixing without prostaglandin or BDA. Even in the atrial level, they are not enough. But I told you, when something encouraging the atrial mixing is that when you have a negative intrathoracic pressures during the spontaneous breathing, not in the ventilators. You understand me?
Yes.
You agree with? Yeah. So when you are, if your patient is just extubated, just have septostomy, he came to you intubated, I think is rushing to stop prostaglandin is just to satisfy the interventionist, but it doesn't help the patient. Most of them, because of the positive pressure intrathoracic, they will need more blood to the lung to improve the mix.
Yes. Okay. My last question. Sorry for my lot of question. My last question: in the normal baby without TGA, who's having significant BPHN and he's in need of nitric oxide, and they will use also the prostatin to keep the duct open as it is venting and keep the baby alive. Is it the same concept in TGA that was having significant pulmonary hypertension or nitric to also use the prostaglandin to keep the duct open?
Well, unfortunately, in the normal baby, and there is around 20 to 30% of them, they are not respond to the nitric oxide. This is the BBHN, and that's why we have to use another thing, prostaglandin or Busantan or another medications. Keeping the bidet open, will fit the right ventricle, but in the same time, you need it. The prostaglandin also work in the reducing of pulmonary vascular resistance.
Yes.
The prostaglandin is helping in the reducing of the pulmonary vascular resistance. So we are just using more than one side to help the patient to reduce the pulmonary vascular resistance. If you don't find the right ventricle, sorry, the left ventricle, it's sometimes it's not a big deal in a small baby because the left ventricle is still strong, but you are not having a good mixing at least.
Yeah. Thank you so much, Dr. Omar. Thank you so much.
You're most welcome.
Dr. Omar, there is one question in the chat box. He's asking, did these babies presented very sick since birth or deteriorate over hours? And also he's asking, how can I convince the cardiologist for urgent septicectomy during time of non-stability and sending him to cath lab?
You know, this is really what I talk about. Most of the cases not in our centers. So when I review their report and the referral, they are stable when they are born, and most of them they are few hours to 1 day old when they came to us. How to convince the cardiologist? I think this is the lecture. I put this lectures to just give you more evidence. And that's the point. And I spoke in this lectures and I choose this subject because I see the patient, and some people, they don't believe it. Or when the patient becomes sick, he doesn't want to do anything. And this is not the case. I think the case is to start everything, try to take the patient for balloon arterial septicectomy. And most of the people, they can just do it a bedside if they have no cath lab.
Dr. Ahmed, can I have just a comment? Because I reviewed my paper regarding the PFO and BD in patients with the TTG.
Okay, go ahead, Dr. Ali.
Assalamu alaikum. Afwan. Because as you mentioned, Dr. Omar, there is no comments about diagnosing or predicting the presence of BPHN antenatally in patients with DTG. But if we diagnose the DTG, so that we have to advise to deliver the baby in a center where balloon arterial septicectomy could be done, or cardiac surgery is visible. And we have to assess the interarterial septum and the restriction at the PFO, the restriction or no restriction at the PFO. But sometimes is it balloon arterial septicectomy, if we diagnose that the patient's having ETG and we suspect that there is BPHN with echocardiography, so that by echocardiography, as you mentioned, the shunt throughout at the atrial level will be right to left, from the right atrium to the left atrium, instead of being from the left atrium to the right atrium. And also in the ductus, it will be also from the pulmonary artery to the aorta, so that there will be venting of the blood from the pulmonary circulation, and no blood will go to the lung to be oxygenated. Even though we do balloon arterial septicemia, the patient will not improve except after reducing the pulmonary vascular resistance, and he might also require an urgent cardiac surgery at arterial switch.
Dr. Omar, you are muted.
Assalamu alaikum.
Sorry, doctor. It's just 1 minute. But balloon arterial septicectomy is not for to help for BPHN. Balloon arterial septicectomy is part of whole preparation for patients with BPHN to have good mixing, to be ready the minute they are dropping their pulmonary vascular resistance, they have good mixing in the atrial level, and because the reversal of the flow will be come back from the BDA back to the pulmonary, and they will be okay, improving. Of course, it's not a treatment, but you should not keep it just because you are seeing that the patient, because they improve in few hours. In few hours, the patient they improving after you start nitric oxide. Okay, thank you.
Okay.
There is another question regarding use of nitric oxide. Is it easy to be used in primary hospital or need special skills? And what about use of sildenafil or magnesium sulfate in BPHN?
Okay. For nitric oxide is very easy. The uses of nitric oxide is very simple. You can use it for anywhere. It usually is oxygen cylinders with, you just remember the equations and you connect it to the ventilator. You just need to know how much the flow of the ventilator and you give how many parts per million. You usually between 20 to 80 parts per million, and that is enough. So it's easier than anything. Now, sildenafil, the problem with the sildenafil is if you have IV sildenafil, is okay. If you don't have IV sildenafil, then you are depending on the oral, and you don't know how long it will take to be absorbed from a gut of the neonate. Now, the magnesium sulfate, it is an old regimen for children with the BPHN, and it's the problem with the magnesium sulfate is the severe hypotension which is created, and most of the patients with TGA BPHN is usually they are hypotensive and they need more inotropic support.
Another question, maybe you answered. If nitric oxide is not available, what other effective pulmonary vasodilators?
I said the Ellobrust is also available. Ellobrust nebulizer, you can use it. Ellobrust nebulizer you can nebulize it for the patient, and sildenafil you can use it, bosentan you can use it, but this is the problem is the time to improve and respond. The nitric oxide is very quick responding.
What about use of milrinone in patient with TGA and BPHN?
Yeah, of course, it is one of the medication for BPHN. Milrinone is also reduced the pulmonary vascular resistance, augmenting the contractility and improve the diastolic functions, and it is one of the good medications. But it's not the first line. You should use it with other medication. You cannot say I will use milrinone, I will not use the nitric oxide. Should be the first line of management. If you don't use it, try to use another medication of advanced pulmonary hypertension medication. Then if they are not, if you are using them, you can use milrinone also to reduce the pulmonary vascular resistance.
Dr. Omar Al-Junaid, yours now.
السلام عليكم دكتور عمر، جزاكم الله خير على المحاضرة. سؤالي هو بارك الله فيكم. What is the effect of BPHN on the decision timing of the surgery? Do we need to ask the surgeon to go earlier or later? Thank you.
No, in fact, doing a urgent surgery in a patient with BPHN is very high mortality and morbidity, and I think nobody will agree to take a patient for BPHN. Usually what happens is usually the surgeon, they think that if he's doing a switch, he will improve saturations. That's why the point. But it's just imagine a patient with severe pulmonary hypertension, you will put him in a bypass pump, you are switching his coronary, the myocardium will be dysfunctioning, plus the pulmonary hypertension, and this is very bad for the patient. Does it mean it's not done? It's not done, but it's not for treatment of pulmonary hypertension. Treatment of pulmonary hypertension is a medical. You have to control the pulmonary hypertension in the medical. Otherwise, the patient will die in the table or will come in ECMO. Now, what is the other line? Yes, if you go to still, what's the other line? I said one of the other line is the ECMO. You put a patient in ECMO until the pulmonary vascular resistance drop, then you back to the normal. Not to do switch, do ECMO. You understand me, Omar? So this is the point. It's the surgery in the patient is ECMO.
So that means we will wait till the patient become in a better shape.
Yes, of course, sure. The mortality is very high. No surgeon will accept him. The surgeon usually the surgeon they do when they misunderstand there is no good mixing, and they will go on to do switch because they are thinking there is no good mixing. But it's not the case here. If the patient with BPHN, you have to treat the BPHN. If he goes to surgery, he should go for ECMO. Yeah, it means as venous ECMO just to improve his oxygenation until the pulmonary vascular resistance drop. Yes.
Thank you.
If you allow me, Dr. Omar, to just add a comment for this multiple question regarding the management. You mentioned in your lecture that the first line of management to stabilize the baby. So this is the most valid things, that to stabilize the baby, sedate well, ventilate, lower ventilation strategy, and paralyze if need to decrease the oxygen consumption, and treat aggressively acidosis, good inotropic support, good volume, and then wait and observe serial of echoes. This mostly will, by time, few days, the VPHN will decrease, and you may not need to use any anti-pulmonary hypertension medication. Most of the cases like that. But and the surgeon never will take a patient who's having high pulmonary pressure until it will drop. That's why the optimal time of surgery usually after 3 days and within 3 weeks. So this is a time where the pulmonary pressure will drop. Thank you so much.
شكرا دكتور. طيب شكرا.
I think there is no more questions. So, Dr. Omar, you would like to add anything about the society in general? Because I think about the topic there is no more questions.
شكرا دكتور Ahmed. Thank you everybody really for their attendance and participation in this, and we are looking forward for another lectures and meetings. I hope this you spread the message for all the bodies and they work hard to save the patient. Really, just talking because we see the patient who we lost and we feel sorry for them. For our society, of course, it's not our society, it's a society for all and for everybody, and we are happy for everybody who want to participate in giving a lectures or anything. Just contact me or Dr. Ahmed Zahrani, and really will arrange a meeting like this with all the people. Thank you very much for your attendance, and thank you, Dr. Ahmed, for the presentation.
Thank you, Dr. Omar, and thank you for everybody who attend with us and support us. Thank you.